Dean, Javier Nieto. And Javier joined us this last fall as our Dean. And we all got to meet him during the search committee and learn a lot about his leadership experience and expertise and why he wanted to come here, but we didn't hear a lot about his research. So today, this is the opportunity we get to learn more about his expertise and his interest in research. So you know, and you can see here, he has multiple degrees. He has a degree in medicine and several, as a matter of fact, 3 degrees in epidemiology. So he's quite accomplished with academic degrees. He has a rather extensive research portfolio, body of research that has focused on survey research, cardiovascular disease, epidemiology and health consequences of sleeping disorders. And his current research interest is more of the sleeping disorders, and you're going to see he's going to talk about sleep, chronic disease, and health. So that'll be his focus today, and I think that's his current research interest. He'll address those.
Current? In my spare time? Yeah.
In your spare time. Okay.
In my spare time, I do sleep, so I'll try to.
Okay. All right. So I just wanted to just let you know that he is quite accomplished, that he's been a principal investigator on numerous research grants, very well published with over 250 publications, and we're delighted to have him here today to tell us more about his research interests, whether they're current, emerging,
or future.
Or future. Okay, please join me in welcoming Javier.
Thank you. John just asked me about flashback to being in this room, in this position, almost a year ago. It was very different. Much more pressure. And I'm still nervous, but maybe not as much as I was a year ago when I was here. Is this okay? I don't know. See how it goes, okay? So let me start with a personal story. I went to my first primary healthcare doctor appointment last week in a clinic near here. It's, I don't want to be into a commercial for the clinic, so it's kind of hidden there. This is the first page of the form they make you fill up, and then that's the second page, the reverse. As you see, I have very busy slides. Of course, I'm not expecting you to read anything. They ask me about everything you can imagine: headaches, head trauma, glaucoma, pyuria, urgency to go to pee in the middle of the night, whether I'm bleeding here and there, rashes, asthma, personal history, family history, how many of my sisters were disease, etc., etc. All the difficult questions. Am I doing something wrong?
Go ahead and take it off.
Oh, moving away?
Go ahead and take it off, and we'll just use the overheads.
Really? No, I'll see how it goes. Maybe not. Where are the overheads? Oh, they are overhead mics. Will they pick up okay, the sound?
You should be fine if you enunciate. You should be fine.
All right. So you fill this up in the waiting room while you're waiting for your doctor to call you in, and then let me give you a quiz here now. What's the total number of questions about sleep in that form? One. 0.00. One single question. I actually gave the doctor a hard time. I think I'm going to try to. My hope is to convince you by the end of this talk that how crazy this is. It looks to me like physicians, medicine in general, and also public health are kind of staying away from sleep for very strange reasons, based on what I think I'm going to, I hope I can show you today. So let me start with just one of the earlier studies that brought up sleep disorders, specifically sleep apnea, sleep disorder breathing to the forefront of interest in cardiovascular epidemiology. It was studied out of Stanford in 1977. It's a clinical case series in the first, what I think was the first sleep clinic in the country. Guillemino and Bill Dement funded that clinic. And they have this series. It's a series of 25 adult men that come to, because very serious, severe sleep apnea, they come to this clinic and they noticed that every single one of them were hypertensive. So that was kind of intriguing. I mean, they don't have controls, all that stuff, but all of them were hypertensive. So that prompted some, people started doing research on trying to make the connections, more case control studies, clinical studies, population-based studies where sleep apnea was defined based on the history of snoring, that, as you know, is a key symptom of sleep apnea. Well, before I go into that, because some of you may not be completely aware of what are we talking about, this is a polysomnographic recording of your sleep. You have the brain waves, the electroencephalogram there, the chin EMG and electromyogram measuring the movement of your muscles in your face. This is the saturation of oxygen measured with this oximeter in your finger. Your breathing measured with a thermostat in a thermistor, sorry, in your nose or your mouth, and your blood pressure and your ECG. So you see a person here who has what we call a hypopnea. This is 10 seconds, so you have an idea. This is 10, 15, 20 seconds, where the breathing goes, the amplitude of the breathing, air going in and out, diminishes because of partial obstruction of the airway. And this person is snoring. That's when the snoring occurs, when the airway is narrower, and then the air going through makes noise. That's snoring. So what happens? Well, because the person is not breathing properly, oxygen level in the blood starts going down until the carotid bulb picks up the signal that we're in trouble here. We are not breathing, our oxygen is going down, so do something. So it sends a signal to the respiratory center in your bulb, and it makes an extra, sends signals to the muscles in the chest and abdomen to make an extra effort to overcome that obstruction in the airway, and the person recovers breathing. That's the arousal that occurs, and then associated with an acute increase in blood pressure, an acute increase in heart rate. Now, in this case, the person, after a few other breaths, goes into complete apnea. In this case, no breathing whatsoever. The person is not snoring, simply still trying to breathe, but not being able because of the obstruction. Again, same thing happens. Desaturation followed for another arousal, etc. So we measure the severity of this syndrome, sleep apnea or sleep disorder breathing, by counting the average number of hypopneas and apneas that occur per hour of sleep, the so-called apnea-hypopnea index. So we did study, again, this is a long story, but just going to give you a brief overview. We published a study where the frequency of these pauses, partial or complete pauses of sleep, occur per hour of sleep, less than 0.5 per hour, up to more than 30 pauses per hour, were associated with increasing odds of hypertension. This is a population-based study. More than 6,000 people that we went to their homes, wired them up to a polysomnographer, and measured their blood pressure. Mm-hmm. And we observed this very strong and significant association. Now, that was cross-sectional, so you always have, you have to consider the limitation of cross-sectional data when you measure both sleep and blood pressure at the same time. But about a few weeks later, it just coincided that the Wisconsin sleep cohort study group, that was before I was in Wisconsin, published this other study, prospective, that is, people who didn't have high blood pressure at the beginning of the study were followed up to, in this case, was about 15-year follow-up. And they found the same thing, in this case, incidence of sleep apnea was more than four-fold higher in those with more than 15 apneas or hypopneas per hour compared to those who didn't have any, even after controlling for demographics, etc., etc. Now in a prospective basis. This is another more recent study that we published with a group of researchers in Spain, basically finding the same thing. This is cumulative incidence of hypertension, comparing those without and those with mild, moderate, and severe apnea. Same thing. People free of hypertension at the outset of the study, follow up, huge difference on the incidence of hypertension. Now, we are epidemiologists, right? So I just give you 3 or 4 studies. There are dozens or maybe even hundreds of studies, clinical, observational, epidemiological studies, all of them showing the same thing. Now, observational evidence showing that obstructive sleep apnea is associated with hypertension. So what's the question now? The first question we ask ourselves, the EP1 question.
Why?
Norm. Is that confounding? Confounding? Would be confounding? Why?
Obesity.
Because of obesity. Yeah, of course. Obesity is associated with increased risk of obstructive sleep apnea, and it's also a risk factor of hypertension. So it's an obvious potential confound, right? So we control for obesity, we control for BMI, and we, in fact, as we expected, the association weakens until it becomes insignificant, highly significant. And the same in the Wisconsin cohort. They did the same thing. They adjusted for BMI, and not only BMI, but also waist circumference, neck circumference, and a marker of obesity that is very, for obvious reason, closely related to sleep apnea, alcohol use, cigarette use, etc., and they still see almost threefold elevated risk of hypertension, even after controlling for those risk factors. And now we go to animal models. Interestingly enough, humans are the only animals that have sleep apnea. We are the only animals in the entire universe that have a piece of our airways that's soft, that collapses when we have sleep apnea. All of the other animals have either bone or cartilage, something that is rigid, not soft. Do you know why that is? Huh? So we can talk. So we can talk and sing. We have this vulnerable, breathing is a pretty important thing. I think you agree with me. So yet we have this vulnerable spot in our throats that in some people, particularly in obese people, collapses. And then we have this problem. So it's kind of a side effect of our ability to have opera, let's say. But there are these researchers out in Canada, in Ontario, in Toronto, they developed this model, these dogs, poor things. They insert this cannula in there with a little balloon in their throats, and they inflate the balloon intermittently, mimicking what a person with sleep apnea has in terms of collapse of the airways. And so they create a model for sleep apnea on these poor dogs. And what they observe is that when they measure their nighttime blood pressure, this is the control before they do this to them, after 1-2 weeks, after 4 weeks, and then they stop doing those things to them. And then blood pressure during the night goes back down in those dogs. But what they do also is, another group of dogs, rather than doing that thing with the balloon in their throats, they actually set them up every now and then. They induce arousals by just waking them up without the obstructive sleep apnea episode. And they So is it the breathing or is the arousal that is causing the phenomenon? But what's critical is that when they measure daytime blood pressure, the increase in blood pressure is only observed in the dogs that are subject to the breathing pauses, not in those that are subject to sleep fragmentation. That's supporting is the breathing, it's the lack of breathing, is the hypoxia induced by the collapse of the airways. What's the problem? And then we have clinical trials. We have clinical trials of patients with hypertension who are treated with CPAP, which is this device that creates a positive blood pressure in your airways during the night. You wear this nose thingy. Mask. That's a good word. And keeps your airway, keeps all a positive pressure in your airways so that the throat doesn't collapse. In a number of, this is a meta-analysis of a number of studies that have shown some of them were small, some of them has some methodological problems, issues that we are not going to have time to get into it. But in any case, there is a consistent tendency of comparing these randomized trials of a decrease in blood pressure associated with treatment of sleep apnea with CPAP. Now, forward 30 years, now it's 2014, this is the gurus of hypertension experts in the country getting together to produce the 8th edition of the recommendations for blood pressure management, the so-called Joint National Committee for Recommendations of Blood Pressure Management. Another quiz. Total number of times sleep. 0.00. Not one word about sleep. 2014, the world experts on hypertension management, they don't even recommend that the physician ask a hypertensive obese patient, do you snore? Not even that. I mean, it's not like, so it's just absolutely shocking. It's not just blood pressure, it's risk of stroke, which is also associated with hypertension, of course. Many studies, including our own, this is from the Wisconsin sleep cohort as well, 4-fold increase in the odds of stroke associated with in a prospective study with sleep apnea. From my friends, my colleagues in Spain, also a multi-center study in hospitals in Spain. This is a follow-up of patients referred to hospitals because of suspicion of sleep apnea, and they, in this study, is not randomized, but they, compared to controls, patients that were not in those clinics, this is their incidence, couple of major incidents of cardiovascular disease. This is heart attacks and strokes, similar to those who are snorers, but in the study didn't reveal that they have sleep apnea, and those who had mild sleep apnea, and those who have sleep apnea, but were treated with CPAP. No difference whatsoever in the incidence of heart attacks. But this is the incidence and those who have severe sleep apnea and refuse the treatment. So now it's not a randomized trial, because at this point it's not even ethical to randomize somebody who has sleep apnea to not to be treated, but yet you have this huge difference that will be hard to explain just by the traditional explanation of placebo effect and all that stuff. And then you think of the pathology physiopathology or pathophysiology of heart disease. So you have the coronary artery that is narrow because you have atherosclerosis, right? And then you think of a condition that will decrease the oxygen level in your blood while increasing the demand because of increased blood pressure and increased resistance, because of blood pressure and increased heart rate. So that's what I just showed you. Sleep apnea induces all those three things, and you can actually see it in a polygraph. It's not rocket science. And yet, And also, we have done studies looking at potential mechanisms, and we have seen that endothelial function worsens in people with sleep apnea. The flow-mediated dilation of the brachial artery after being subject to ischemia. There's a reduction in the response on the endothelial response to ischemia in subjects with sleep apnea. We have done studies, and others and finding a strong association between sleep apnea and the risk of the metabolic syndrome, which is not surprising because it's associated with obesity, of course. And yet again, this NIH American Heart Association panel, all the experts, well, not all of them, but great experts, Paul Sorley, Wayne Rosman, Larry Apple, Darwin Laward, good friends of ours, great colleagues, great epidemiologists, experts in cardiovascular disease prevention, published this consensus, results of this consensus conference on health promotion and disease reduction of cardiovascular disease. Number of times sleep is mentioned. You know the answer. Not much simpler than that. So it's kind of, anyway, kind of crazy. But, so again, they keep saying, or they keep thinking, I think. That's why they keep ignoring it. Because, oh, yeah, it's well, number one, not everybody who has sleep apnea is obese. That's one thing. But also, could it be, why does obesity produce hypertension or heart disease? Could it be that rather than confounding, or maybe a little confounding, but could it be that sleep apnea is one of the reasons why obesity is associated with hypertension? Could be, so not just the issue of, more than issue of confounding, it could be just OSA is one of the mechanisms. And actually, could it be the other way around? Could it be that obstructive sleep apnea induces obesity? Would that make sense? Well, obstructive sleep apnea, like other sleep disorders, results in poor sleep. And people who don't sleep well, they are less physically active and have more appetite. That has been extensively demonstrated. So, which will result in obesity. So we may be talking about something that is like circular here. There is a circle. There are plenty of studies. This is an old slide, 2008. There are many more published in recent years, both in adults and children, that show a very strong relationship between, in this case, sleep duration and obesity. In our cohort in Wisconsin, there's this. This is average sleep. A nightly sleep in members of the cohort, 6, 7, 8, 9 hours. There's this U-shape on the mean body mass index associated with number of hours of sleep. We are particularly interested in this end of more than this one because, in my opinion, this maybe have a different meaning. People who sleep too much, maybe people who are depressed or that long sleep is more a symptom of something wrong with them. So we are not focusing on that, we're focusing more in this end. And increase, like in all the other studies that I showed you, in this case, BMI associated with short sleep. And in that study, we also show that there is an inverse relationship between number of hours of sleep and levels of leptin, which is an appetite suppressor hormone. And conversely, a direct relation, an inverse relationship with ghrelin, which is appetite stimulating hormone. So short sleepers have more ghrelin and less leptin. And that's something that, again, that study was observational, but has also been shown experimentally in volunteers. This is a small sample, 12 healthy men who were subject to normal sleep and then sleep deprivation, and they measured their hormones, and they found that sleep reduction was associated with a decrease in leptin and increase in ghrelin, experimentally induced. So first conclusion of my talk. Breathing is good for you. Again, this is something that I'm having a hard time understanding, why my colleagues in the cardiovascular health field are having a hard time understanding or admitting or considering as something that could be potentially explored in their patients. But anyway, that's me. I don't know. When I went to medical school, they told me that breathing was. But the silver lining for us, the reason why I'm not too upset with this is because this keeps happening over and over and over in medicine. This is 1908 and 1913, researchers in Russia and Austria showing that when you feed rabbits with high cholesterol diet, you induce atherosclerosis. This is the actual, they didn't have PowerPoint or this is the actual drawing. They draw their pictures in their paper. The atherosclerotic plaque in an artery of a rabbit that's been fed with cholesterol concentrates. This is 1908, 1913. Well, it takes epidemiologists 30 or 40 years when there's the first report out of the Framingham study showing that in humans, high cholesterol levels are associated with higher rates of heart disease. This is one of the earliest reports from the Framingham study, started in 1950 to 1957. American Journal of Public Health was published. The first report in humans showing that cholesterol may actually be a problem, high cholesterol. Well, it took 20 years for the NIH to publish their national recommendation, National Cholesterol Education Program. We should educate people about the population about 1985 about cholesterol, dietary cholesterol, and heart disease risk. And then 10 years later, this definite randomized trial showing that cholesterol reduction with pravastatin was associated, in this case, was lipid lowering agents were associated with statins, with a significant reduction in risk of heart disease. And another example, so anyway, we are, 40 years since the earliest studies by Guillemino, and we are still where we are. In case of cholesterol, took 60, 70 years to get to the mainstream. So, we're still within the frame. Inflammation, that's the other hot topic in cardiovascular disease epidemiology, as you know. Russell Ross published this New England Journal article right after he died. That came to print. Russell Ross at the University of Washington was the pope of pathology of cardiovascular atherosclerosis, the injury response hypothesis, and all that stuff. Well, he, in 1999, this is his scientific testament, declared atherosclerosis an inflammatory disease. It was completely revolutionary. Well, let me read this quote for you. Somebody talking about a form of atherosclerosis in which we can distinguish a stage of irritation, perceiving the fatty metamorphosis comparable to the stage of swelling, cloudiness, and enlargement, which we see in other inflamed parts. I have therefore felt no hesitation in siding with the old view in this matter and admitting an inflammation of the inner arterial coat to be the starting point, the so-called dermatous degeneration. Anybody could guess who said this?
A paper from 1908.
A paper from 1850. This was Rudolf Virchow, who many consider the father of modern pathology. Is the guy who said we should study cells. 1859. He was talking about the old view of atherosclerosis was an inflammatory disease. Now, what? It's 150 years later that Russell recognizes that as the fact. Well, this other person was talking about atheroma deposit being regarded as a product of an inflammation of the arteries. The chronic inflammation of the cellular sheath of the vessel is almost always a secondary consecutive appearance which associates itself with the already established deposit. So this person is saying, it's not really that atherosclerosis inflammation, it's that as a result of atherosclerosis, we have inflammation of the artery as a reaction. That was Rokitansky, who was Virchow's arch enemy and rival in the pathologic world of Germany in the mid-19th century. Well, JAMA, 2009, there is this paper discussing whether inflammation is primary or secondary to atherosclerosis. The exact same thing Rokitansky and Virchow were discussing for 50 years. So I think this is why we call all this research. So let's switch gears a little bit and talk about cancer. So 2002 and in the late 1990s, 2000, early years of 2000s, studies started documenting the strong potentially strong role of hypoxia on promoting tumor growth and metastasis in general, and especially as a result of the angiogenesis processes. So, mediated, there's a lot of laboratory research and basic science research pointing out that the expression of hypoxia-inducible factors, particularly HIF-1 alpha, increases when the cancer tissue is subject to hypoxia and promotes the secretion of angiogenic factors to bring more blood vessels and more blood to the cancer that is being hypoxic, and that results in potentially in growth. Tumor growth and metastasis and poor prognosis, and resistance to radiation, etc. So those are laboratory studies. They're culture cells studies, cancer culture cells that are subject to hypoxia. They are put in boxes with no oxygen or little oxygen, and then the cells compared to normal cells are subject to intermittent hypoxia in this case. Have a higher concentration of vascular endothelial growth factor, and so which kind of makes sense. So just fast forward a few years, and this group has mice who are injected a little chunk of human melanoma tissue, and then they subject the animals to cycles of hypoxia. 10-minute cycles of they subject the mice to 10 minutes of in a hypoxic environment during 4 hours, and then they let them be. Another control mice breathing normally, normal air, and they find that compared to those to control mice breathing normal air, hypoxic mice have higher incidence of micrometastasis in the lung, and higher index of microvascular density, so more angiogenesis, and increased levels of vascular endothelial growth factor. Again, consistent with what the laboratory experiments were showing. So, then my friend Ramon Ferrer from the University of Barcelona, who is a researcher in sleep apnea, is a physiologist that does research, a respiratory physiologist in sleep apnea, is looking at these studies and thinking, well, the problem with this is that these cycles of intermittent hypoxia are too long, are not similar to what we experience with a human with sleep apnea really experiments. So he devises he sees our just published in 2008 a follow-up study of our Wisconsin sleep cohort, 20 years of follow-up of the cohort starting in 1989. and up to a few years ago, and we observed this very strong increase in total mortality in those with apnea, hypopnea index of more than 30 compared to those with moderate or mild or no sleep apnea, a threefold increased risk of mortality associated with severe sleep apnea. Okay? So Ramon sees this paper and notices something that, so the paper was aimed at describing the relationship between sleep apnea and total mortality. And cardiovascular mortality, because we were interested, that was our interest at the time, and we had more power to do that. The study was really not powered to look at or designed to look at cancer. But he notices that in table 1 of that paper, there is those without this was descriptive data in cancer. Those with no sleep have 2% incidence of cancer mortality. Compared to those with severe apnea, the numbers are small, but there's an 8% difference. 8% incidence. So it's a fourfold difference. So he puts everything together and decides to create this experimental model, these animals, again, injected a fixed amount of melanoma tissue in their flank, and he puts these mice in cages. Control mice breathe normal air, and experimental mice breathe air that becomes hypoxic at a periodicity and an intensity similar to what a human with sleep apnea experiments. 20 seconds of only 5% oxygen in the air, alternating with room air for 40 seconds. 60 times an hour. So this will be reproducing an individual with an AHI of 60, which is fairly severe sleep apnea. This is what he finds. This is the melanoma tumor growth in the control mice. This is the melanoma tumor growth in the hypoxic mice. And interestingly, he also observes that in mice of subject with intermittent hypoxia, the levels of VEGF increase. So he comes to us and said, could you guys look at specifically cancer mortality in your cohort? And we did. Now we have a few years have passed, so we have numbers are a little higher. This is the distribution of our cohort according to absent, mild, moderate, or severe sleep apnea, or sleep disorder breathing, same thing. And again, we see that there's a significant trend in increased cancer mortality, total mortality, as we described in the previous paper. But again, what Ramon observed in that table 1, now verified with a longer follow-up, significant increase in cancer incidence, age-adjusted cancer incidence in this case. When we ran Kaplan-Meiers, we saw exactly the same thing we observed with total mortality. Now this is cancer-specific mortality. That when we ran Cox regression models adjusting for BMI, adjusting for diabetes, adjusting for everything we could think of, smoking, alcohol, we observed an almost 5-fold increase in cancer mortality risk compared to those with to those without sleep apnea. And what's interesting is that if instead of counting the apnea-hypopnea index, that is the apnea-hypopnea events per hour, if instead of that we classified participants in the study according to the level of oxygenation during the study, so to speak, what we call the hypoxemia index, the percentage of the time during sleep that they are below 90% saturation of oxygen, then the hazard ratio is almost 9. It's a 9-fold increase in risk of cancer mortality. Which is, again, this is observational, but I've never in my life, other than smoking, with smoking I found risk ratios of this kind. And again, this is adjusted for all the other covariates that we can think of. Other studies since have been another study from Spain, this study in Australia showing the same thing, not as strong effect, but same thing with cancer mortality. Now the question is, again, this is observational. We don't have definite evidence yet, but there is clearly an association between sleep disorder breathing and cancer mortality. Now, what does that mean? Could it be that sleep apnea increases cancer incidence, and then more cases, there's more mortality? The evidence is not clear. There have been some studies published in the last, this is very new, this has been only, papers on this are becoming available in the last 2 or 3 years. Very few studies on cancer incidence, very mixed results, but more consistent results on studies looking at mortality. And what in my opinion is happening here is that it's more than cancer incidence, more that once you have cancer, your cancer becomes more aggressive if you have sleep apnea, for the reasons which they saw in these experimental studies. It's a simple reason that the hypoxic tumor, hypoxia being aggravated with this intermittent hypoxemias that an individual with sleep apnea has, would secrete more angiogenic factors that would promote more vascularization of the tumor, and thus more opportunities for metastasis. So it makes total perfect sense. The Spanish group has published more recently other studies looking specifically at metastasis, and again showing the same thing. Melanoma-induced cancer in mice that are comparing those with normal air and those with intermittent hypoxia, the incidence of metastasis in the lungs are significantly higher in the mice with intermittent hypoxia. So sleep apnea has been associated with, early on we were thinking of mortality, hypertension, cardiovascular disease, metabolic syndrome, obesity, now cancer, but it's also been associated with a whole host of other undesirable health outcomes. Depression, decreased quality of life, decreased work productivity, occupational injuries, traffic injuries. Just to give you, we don't have time to go through all that, of course, but just to give you a couple of examples. This is from the Wisconsin sleep cohort looking at incidence of depression in relation to increasing levels of sleep disorder breathing. Traffic accidents. This is from Spain in the 1990s, a study that showed that, particularly when combined with alcohol use, there's an interaction with alcohol use. The risk of is an 11-fold increased odds of traffic accidents or car crashes in associated sleep apnea. That was not as strong when alcohol was not used. So a potential synergistic effect between alcohol and sleep apnea as a risk for motor vehicle accidents. Other sleep disorders, also, this is a very, very much still emerging area of research. Sleep deprivation, is insomnia, and more recently even shift work as potentially associated with health, with potentially serious health consequences. This is an early study in the 90s out of Hopkins, the precursors study, looking at incidence of depression associated with insomnia in a graduating class of medical students at Hopkins. This is more recent from our group in Wisconsin, in the Survey of Health of Wisconsin, looking at shift work compared to traditional work hours, and demonstrating this increased risk of obesity, and not significant in this case. Other studies have shown significant association of type 2 diabetes. Shift work associated with metabolic syndrome, particularly when combined with insufficient sleep. This is another study recent study from a Swedish cohort showing breast cancer in association with shift work as well, particularly among women with have been doing shift work or working non-traditional hours for a number of years. This is a very emerging area of research as well. That is associated with altered levels of melatonin, which is a well-known inhibitor of breast cancer risk. So, second conclusion, breathing is good, sleeping is good. They all, and this is something that, you know, believe it or not, is becoming, I think it's only recently being more appreciated. We have this whole idea of sleep as simply a period of rest. And then some people can rest more or less, and that's okay. Well, it appears that it's not just that. It's not just resting or sleep or resetting, whatever. That this is a paper in Nature, a commentary a few years ago. This guy was saying, if sleep doesn't serve an absolutely vital function, it's the biggest mistake evolution ever made. And it's very true. All the animals sleep, and sleep a significant amount of time during their day. And you know, sleep is not good when you are out in the savannah or in the forest. Why? You are getting eaten. You are at high risk when you sleep. And yet, all the animals sleep. They don't have a choice. You get animals, mice, and you deprive them from water or from food, and they die after a while. You deprive them from the sleep, and they die too. They die. It's an absolutely vital function. This was in Science last week, out of our friends in Wisconsin, actually. Giulio Tononi and Chiara Sfirelli, researchers in Wisconsin looking at their neuroscientists, synaptic scaling across the wake-sleep cycle, which in English means, what's the purpose of sleep? To forget, science is saying. This is an article that appeared in the New York Times, interestingly enough, the day before it appeared in Science. They have a preview, I guess. And it's a very interesting article. You can find it just published 2 weeks ago. February 3rd, discussing the mechanism, the important neurological functions that sleep does in terms of trimming our memories that we accumulate during the day, so we can keep functioning ahead. Otherwise, our heads will be completely full of stuff. Can you imagine if we couldn't forget what we did the day before? I guess it's like the email here that you have to clean up, otherwise it gets full and you can't receive anything else. Sleep is a vital psychological process, and sleep disturbances can have severe and potentially devastating health effects. And yet, as I showed in the very first slide, primary healthcare physicians, internists, cardiologists, neurologists, psychiatrists completely ignore sleep, or for the most part. I think it's starting to change a little bit, but very, very slowly. Direct questions on sleep. This is a research out of Minneapolis, other study also recently in Canada, same thing, primary healthcare practices. They look at them, they saw what I saw here in Corvallis, and in Madison with my primary healthcare provider. They don't care about it. They don't ask you. And I'm sure that's something you experiment. Most of you experiment. Maybe you have a visionary physician, but and that's the reason why most sleep disorders are undiagnosed. In the Wisconsin sleep cohort, we found that 82% of men with moderate to severe sleep apnea and 93% of women are undiagnosed. And this is a little old. This is 90s. I think it's probably a little better today, but probably not that much. These people are out there driving. Or going to a psychiatrist because they think they're depressed. They're not depressed, they're sleepy. They're sleepy because they don't breathe while they're sleeping. And, you know, they snore and their spouse is completely miserable as well, and then they get depressed, spouse. Things are changing again a little bit. This is the European Commission on Hypertension Management recommendation. Number of times in their 2013 report, number of times that the word sleep appears. 27. They mentioned it 27 times. Now, what they talk is like more studies are needed. more randomized trials are needed. What we call the tyranny of evidence-based medicine. It's all about, the question is, do we need more randomized trials to do something on sleep and discuss the patients? You all know this study of this meta-analysis. You must have seen it. That this Gordon Smith studied this meta-analysis of studies looking at that parachutes are effective in preventing death from gravitational challenge, and they found no studies. They found no studies. We are unable to identify any randomized controlled trials of parachute intervention. We think that everybody might benefit if the most radical protagonists of evidence-based medicine organized and participated in a randomized, placebo-controlled, crossover trial of parachutes. The prevalence of many sleep disorders is growing as a result of the prevailing social and demographic trends. Emails, Facebook, people are not sleeping anymore. The prevalence of sleep apnea is increasing. It's very substantial. That was in the early 90s in the Wisconsin sleep cohort, population-based sample, 4 to 10% moderate to severe sleep apnea. And estimates in their cohort show that the prevalence has been increasing in parallel with the obesity epidemic, of course. The percentage of people sleeping less and less is growing across all ages and genders, although a more recent study shows there's been some leveling off. This is a prevalence of less than 6 hours per day in national surveys. There was this increase in the 80s and to 2004. It seems to be some leveling off, which is good news. CDC is talking about sleep as a public health, sleep as a public health epidemic. There's great urgency for more research in ways to incorporate sleep health in standard clinical practice and health promotion. And that's all I had to. I'm sorry it went a little over time, but if there, I'll be happy to take any questions.
I've had this question in the back of my mind, which somewhat got answered at the end. I was interested in gender differences, particularly if there have been any large cohorts of women to see if there are gender differences in the way sleep apnea affects their health. And then the second question I have is, have there been any large studies done with long-term effects of treatment with CPAP to see if there's observed decreases in the outcomes that you see with people, particularly with severe sleep apnea?
There was this myth that women did it was not that more that much affected as for sleep apnea as men were. I think that's been invalidated by recent studies. I think it's a problem in women as much as it is men, although the prevalence of sleep apnea is lower in women than men. Maybe some anatomical differences or other factors, I'm not sure, but there is most studies, all the studies I've seen, there's an effect, a relation between the effects of sleep apnea or other sleep disorders equally strong in women and in men. As to the second question, long-term studies of CPAP, not that I know of. Those studies will be very expensive, particularly if you're talking about randomized trials, will be extremely unethical because knowing what we know now about, aside whether, the question is whether sleep apnea causes cancer or heart disease, long-term randomized trials, you could solve that problem. But the problem is that because we know that people who have sleep apnea have other serious consequences in terms of being sleepy and being at high risk of having car crashes, occupational injuries, etc. It's not ethical to have people subject to a placebo, a sham sleep CPAP. So
I have severe apnea though, and I've talked to people. I mean, I use a CPAP and it's changed my life, but I have talked to people who simply can't use them. They just can't do it.
Okay, and that's, thanks for bringing that up. Yes, CPAP, interestingly enough, is about 50-50. There are 50% of patients who are given a CPAP that cannot tolerate it, cannot use it. They cannot sleep with that thing in there. And others that changes their life completely. The first time, I have family members who were diagnosed, in particular one that had a car accident and then was overweight and had a sleep study. His physician, said, "Oh, maybe you have a sleep problem." Sent her to the sleep lab, severe sleep apnea. Wear the sleep app and changed his life completely. He didn't remember how it felt waking up and feeling rested. He had been subject for decades to this disease and never falling into having a good night's sleep. And he goes with the CPAP everywhere. It's the first thing he packs. Takes the suitcase. Yeah?
So it sounds like CPAP is the best that we have right now for treating OSA. My question is so I'm in the School of Global Health, and I myself have obstructive sleep apnea. And I'm wondering, I used to live in Brazil and they would turn the power off a lot at night to preserve energy. So what do we do for people with chronic sleep apnea that don't have electricity? Is CPAP's really our best bet? And then sorry. And then what do we do from there, knowing that it's so prevalent all over the world? How do we...
No, it's a very good question. Well, it's very strongly correlated with obesity. Again, not only in obese people, that's true. But so weight loss is a good treatment if you can sustain it. And other than that, I guess CPAPs with batteries. I don't know.
Solar powered CPAPs.
Yeah.
So, what if a person is a professional opera singer? Is that person less likely to have collapsing airways at night?
That's a good question. I don't know. Maybe she was not. Opera singers, some of them are pretty substantial.
But many of the people who have sleep disorders are not obese.
Yeah, no, that's true.
So,
It's the problem with sleep disorders is that it's so hard to do research in sleep disorders because often there are consequences as well as causes of diseases. Sleep deprivation, insomnia, and depression. What comes first? You are insomniac, you are depressed, you don't sleep well. It's very hard to disentangle. And the same with sleep apnea and obesity. What comes first? And that's the challenge with siestas. I can give another talk about siestas. Siestas, I'm absolutely convinced is good for your health, taking a good nap in the early afternoon. But yet, it's a symptom of sleepiness in some people. So some studies found that people who take siesta are less healthy. But is it because of the siesta, or is it because siesta is a marker that something else is wrong? It's very hard, but anyway.
Yeah, can you talk about the role of the sympathetic nervous system possibly in activating?
Sympathetic nervous system is definitely, there's a measurable, I actually had a slide on that, and I dropped it out because I have too many. There is increased rate of sympathetic activity in subjects with sleep apnea. And in fact, there's a study showing that when I talk about the connection between obesity and hypertension, one of the mechanisms that there's an increased sympathetic activity in obese people, but that study observed, I can show it to you, observed that was only the case in obese patients with sleep apnea, not without. And there is a measurable increase in sympathetic tone associated with those arousals. Makes sense, right? Yeah. Thank you.
So if too little oxygen is bad for you, is lots of oxygen good for you, and does that explain why exercise is beneficial?
maybe you should answer that question. Too much oxygen, well, to some extent. I mean, you need to have the right amount of oxygen. No, it's not that more oxygen is going to be physical. It's like almost everything else. Vitamins. Do you have any thoughts on that?
Yeah, well, there's when we're talking about just oxygen saturation, we're dropping below 90%, and then we can raise it back up to 100, but we can't hyperoxygenate at that point. So more will reach a threshold, a ceiling.
I was wondering about the role of stress in all of this, because there were early studies, for example, showing that crowding stress in rats created cross-linkage problems in the collagen, which were leading to arteriosclerosis. And hypoxia could very easily also be a stress, right? That would create arteriosclerosis in the same fashion. And it's reversible if you do it, if it's shortened a period of time, but over a long period of time, it's irreversible. So that might play into some of the slides you were showing. But I'm also thinking that people who are sleep deprived may very well not deal with daily stress very well, so you get another one of these cycles.
Yes. No, I mean, what can I add? Absolutely. Makes total sense what you're saying.
And opera singers don't have the decline in pulmonary function that you see with age in a normal population.
Very done. Yeah.
I'm curious about connections to sleep, interrupted sleep in kids. And I assume that kids don't have sleep apnea. I have no idea.
Some kids have sleep apnea. It's often associated with adenoids, which is correctable. You can correct it with surgery, but then when the epidemic of obesity, we started to see kids who have obstructive sleep apnea as adults, as part of the metabolic syndrome that is occurring in kids as well.
The reason this is super interesting to me because there's an emerging line of work that's coming out showing that just within normative populations of kids, lots of interrupted sleep is associated with lower ability to problem solve and memory and attention. And some interrupted sleep when you're little, is just normative.
Yeah.
But it would be super interesting to look at that. I mean, there's some studies that have come out, but it's actually pretty small, and I don't know how well done they've.
More than sleep apnea, I would think the concern would be right now sleep duration and use of electronic devices before sleep.
Right.
That could, who knows what's producing on the melatonin cycles and the.
We should do a study.
We should.
Yeah. No, serious.
No, I'm serious too. It is. The sleeping kids is. I didn't talk much about that. It's a huge concern because of the exposure of kids to
Before bedtime.
right before bedtime to light. Just aside from the excitement of whatever they are doing, is the exposure to light at the wrong time. That is that has maybe having. I mean, we don't know exactly what's happening, but could have potentially could explain perhaps those altered patterns of sleeping.
Yeah, that would be interesting.
Is there a difference in incidence or magnitude of OSA in people that are nasal breathers versus mouth breathers?
I'm sure there are 1,000 studies about that, but I don't know.
Well, again, anatomically, the difference you described, or at least with people, is that something that's more effective?
The obstruction is in the throat, is in the larynx, is the collapse of the airways. I'm not sure about nose versus mouth breathers. I don't know. I cannot answer that question. I'm sure it's been studied.
We know that depending on how you sleep, the position in which you sleep affects your
Yes.
levels. So you're supposed to always sleep on your back, besides the fact that you also can't sleep on your front because you'll smush the CPAP, but it's recommended that you sleep on your back. And then I know that because the problem's lower down, I have obstructive sleep apnea, as does my father, but his is in his mouth. He breathes through his mouth and I breathe through my nose. When you go into the sleep study, they isolate it. So at one point in the night, you're sleeping strictly through your nose, and another point in the night, you're sleeping through your mouth.
You done?
Oh, I'm just going to say, number one, I just had my doctor check up, so they are all battery operated CPAP.
Wow, that's good to know.
Yes. Can, but it's a little expensive. Two, some of the things that we were talking about, the CPAP use of patient, a lot of them not used to it. And one thing I can use this as a diversity study. The way they design for people with nose like yours or like most Caucasian, they can't do it with mine. It took 2 years to find the right CPAP actually fit, allow one to use. So I'm pretty sure if people begin to study the design itself makes a lot of difference. So.
I know we are going over time. So, but another thing we haven't discussed is issues of schools and school hours and policies with children and forcing children to be at school at 8 a.m. or young elementary school children or my kids when they went to junior high school it had to be to school at 7:30.
High school here,
7:30. That's absolutely incredibly important policy, health policy, research and intervention tool that I would think the college should try perhaps to engage with, because I think it's absolutely insane that we are subjecting kids to this. You know, we are concerned about obesity in kids and performance and cognitive function and learning. We are forcing these kids who are not, they don't go to sleep at 8 or 7.
Your conference is scheduled to end in 2 minutes.
You're a hero.
Maybe it's not a clock. I mean, not high school kids. I mean, they're usually going to bed at 11 and they're happy to get up.
Anyway. It's 1:10. I'm sorry.
So thank